بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. دكتور ياسر طاقة معاكم إن شاء الله. نتواصل إن شاء الله معاكم المحاضرات، وهذه المحاضرة إن شاء الله الخامسة. الحقيقة in the last lecture, the fourth lecture, lecture, I taught you about head injuries from their classifications, point of view, and other views, and then we went to the last classification according to the site of injury. We started from the outside, very outside, I mean the skin, and finished the skin injuries, including the scalp hematoma and scalp lacerations. Then we went to the bone, different types of skull fractures. We talk about them in details. Now we are going to go more deeply inside, I mean the intracranial injuries. As I told you that the head injuries, including the different types of scalp injuries, we talked about them, skull injuries, and now the intracranial injuries, I mean the brain injuries. To start with, types of brain injuries are classified into either primary brain injuries or secondary brain injuries. The primary brain injuries are these injuries which are happening at the time of impact. For example, contusions and laceration of the brain. And usually these are irreversible. For example, if a patient is hit by, for example, a shell. This shell injured for example, the right motor area. This patient will got left side hemiplegia, which will be permanent deficit, irreversible. While secondary brain injuries occur at some time after the moment of impact and is often preventable or reversible. For example, patient got one of the primary injuries, for example, skull fracture resulting in injury to the one of the extradural vessels, I mean the middle meningeal artery. This is primary injury to the middle meningeal artery by the fractured bone. But this injury will result in accumulation of hematoma, which is called extradural hematoma, outside the between the dura and the bone. This type of hematoma is a secondary because it's not present at the time of impact. So that the primary injury was injury to the middle meningeal vessel, while the secondary was the extradural hematoma. So that managing extradural hematoma as early as possible will result in cure of the patient and return as normal person. The management of head injuries in general is aimed at preventing secondary brain injuries or treating the sequel of secondary brain injuries, while the primary injuries are irreversible. Now, what are the causes of secondary brain injuries? They include many causes, like hypoxia, hypotension, systolic blood pressure less than 90 millimeter mercury is so harmful to the brain. Raised intracranial pressure more than 20 millimeter mercury is so harmful as well. Low cerebral perfusion pressure less than 65 millimeter mercury. Pyrexia, seizures, and metabolic disturbance, all these are the cause of secondary brain injuries, which are, as I mentioned, we are aiming at management of injuries to prevent these secondary brain injuries. Now, what are the types of primary brain injuries? In fact, we have the diffuse axonal injury, number 1, cerebral concussion, number 2, brain stem and hemispheric cerebral contusions, and lastly, cortical lacerations. In fact, diffuse axonal injury will affect the whole brain. Diffuse, from its name, diffuse. Cerebral concussion also affect the brain as a whole. While brainstem and hemispheric injuries, here contusions are localized for some area or the other, for example, frontal lobe or temporoparietal. Cortical lacerations also will be localized at the site of injury, for example, laceration by bullet or by shell, or for example, motor lobe of the brain, a motor area of the brain. Now, diffuse axonal injury, here there will be prolonged post-traumatic state in which there is loss of consciousness from the time of injury, and this is quite important. This is from the time, this loss of consciousness starts from the time of injury. That continues beyond 6 hours. It is occurred as a result of mechanical shearing of the gray-white matter interface. What do we mean by this? Shearing means قص, يعني أشمع, separation. This means separation between, you know that the brain having the gray matter outside, the white matter inside. The gray matter are the nerve cells, while the white matter are the nerve axons and nerve fibers. Here what will be happening, there will be separation between the nerve cells and their axons. Exactly as said, for example, between generator and the wires, between the generator and the wire separation. This causes disruption and tearing of axons, myelin sheath, and blood capillaries. Severity can range from mild damage with confusion only to coma and even death sometimes. From this description, you know that, or you see that this is severe injury to the brain and generalized injury to the whole brain. And as far as the primary brain injury is irreversible, and we are just giving supportive measure treatment to the patient and waiting for the results. This is how it happened: severe traumatic brain injury. And then post-mortem patient for brain, you see many areas are affected by damage. This one, this two, this is three or four. Also different types of or sites of injury, diffuse axonal injury. You can see this brain, many areas are affected by this injury and this pathology. And these are the spots of blood. Sometimes also present, many spots of blood are present as a cause of diffuse axonal injury. From its name, diffuse means distributed on the whole sides of the brain. For example, this is also a CT scan of the brain having, for example, compressed ventricles with some brain edema and many spots of blood here or there, and due to diffuse axonal injury. Also, other showing diffuse axonal injury with multiple spots of blood here or there, even intraventricular bleeding is present. Other case of diffuse axonal injury, MRI of the brain. Cerebral concussion. Cerebral concussion also affects the whole brain, but to less extent than less severity than the severity of diffuse axonal injury. Here, what will happen? From its name, there is slight brain distortion. This is a clinical diagnosis and is manifested by temporary cerebral dysfunction. For example, temporary loss of consciousness. From its name, Latin concutire means shake. So that in this case, there is brain distortion but without organic structural damages. And as I mentioned too, it's a clinical diagnosis. Now, the clinical representation of cerebral concussion هذه يعني اكيد سامعين بها كلكم. مثلا يقول فلان والله وقع من السطح صار عنده رجه بالدماغ، هذا نسميه رجه بالدماغ كونكشن. اوكي، مثلا دعم السياره رجه بالدماغ، كمان رجه بالدماغ شائعه وهي مصطلح فعلا كلام صحيح. كونكشن ميز رجه. اوكي، فهذه رجه ممكن تكون يعني تعدي على خير في اكثر من احد. The clinical representation include autonomic abnormalities including bradycardia, hypotension, and sweating. Loss of consciousness often, but invariably, accompanies concussion. It will be trivial loss of consciousness. Now, once there is loss of consciousness, even if it's trivial, this indicates that there is cerebral concussion. Amnesia of events is common. Temporary lethargy, irritability, and lastly, cognitive dysfunctions by abnormal behavior appear by the patient. You can see in this figure how concussions happen. For example, concussion by and vary between shake. For example, hit to, for example, dashboard, and resulting in this concussion. Then a brainstem and hemispheric contusions. Now, more severe than that one, it will be localized here. These are areas of bruising and swelling with intact pia arachnoid, localized or generalized edema, and hemorrhage due to tearing of blood vessels. Now, this is contusion. Contusion, to describe it, it is just like, for example, patient having CVA, ischemic CVA due to thrombus occluding, for example, the territory of the anterior cerebral artery, for example, right side. This will result in right side ischemia, right frontal lobe ischemia, resulting, for example, as far as right frontal lobe containing the motor area controlling the left side, he will got a left side hemiplegia due to occlusion of the anterior cerebral artery. Here, what will happen? This injury, the first one in CVA, caused by ischemia. Here, the ischemia due to direct pressure on that area with, as I said, generalized edema and hemorrhage due to thinning of blood vessels. Cerebral contusion clinical representations as follow: prolonged period of unconsciousness, loss of consciousness, focal deficit that persists for longer than 24 hours. CT scan demonstrate contusions as small areas of hemorrhage in the cerebral parenchyma. Contusions may dissolve with accompanying deficit, or they may persist, so that after their resolution of contusion may result in recurring of the patient movement or may not recur back. To treat this patient, in fact, we are also treating them conservatively because there is no method to treat these methods, just these lesions, just like the diffuse axonal injury, concussion, and also contusions. You can see this is the contusion. The bruises is present at here. This area of contusions. These all are contused brain tissue. Postmortem specimen. All these specimens can be shown the contusion. All are contusions of the brain, and these are the site of contusions. You can see clearly that this is the site of left temporal contusion, mixed areas of hyperdense and hypodensities due to these contusions. So these are all areas of contusions. Also, other areas of contusion. This contusion, this is contusion, this contusion. This is not a clear intracerebral hematoma as we will see later on because it's mixed with other hypodense areas. Now, this is also a case of cerebral contusion involving the right and mainly the left frontal and left parietal temporal area. You can see we did for this patient craniectomy due to increase the cranial pressure as a method of decreasing the pressure or managing the blood pressure. And this is after resolution of contusion. You can see there's still some areas of deficit, I mean, of hypodensity, just like ischemic areas, so that in this patient, I suspect that this patient, after resolution of contusion, he will not return back 100% to normal function of the body. Last type of primary brain injuries are cortical lacerations. Lacerations mean wound of the brain. مثل ما نقول يعني skin laceration الجرح هذا أيضا يكون brain laceration, cortical lacerations. So there is something causing wounding of the brain. For example, shell injury, for example, bullet injury, for example, sharp trauma to the head, or even blunt trauma to the head, like in the fracture. This fracture end inside go inside and rupture injury the dura and the brain tissue. It is due to rapid movement and shearing of the brain tissue. Shearing, يعني قص of brain tissue means wound. The pyarachnoid is torn with bloody effusion in the CSF. Intracerebral hemorrhage may accompany these lesions. We mean that the intracerebral hematoma. Focal deficits are the rule, and these focal deficits will be permanent. For example, as I told you, if the shell injured the motor area, this will be permanent deficit. Also, the management of all brain injuries, as you see, are just conservative and supportive treatment for these patients. This is again a case of cerebral lacerations, for example, by fracture. Now we finished all types of primary brain injuries. Rapidly to return back to summarize them: the diffuse axonal injury, concussion, contusions, and lacerations of the brain, which are, as you saw, that they are unpreventable, untreatable. We just treat the patient, just supportive measures to the patient. Now we are going to the most important are the secondary brain injuries because these are preventable, and in the management of head injuries, we are aimed at preventing these injuries or their sequelae. They include many, about 8 types of secondary brain injuries. Start with the brain edema, cerebral swelling, intracranial hemorrhages. Now be aware of this term, intracranial hemorrhages. This is not intracerebral, it's intracranial. When I said intracranial, I mean anything inside the skull. Any bleeding inside the skull is called intracranial. Most of the students are make sometimes wrong answer when I show them, for example, a case of intracerebral hematoma. They say this is intracranial hematoma. Yes, all of these are intracranial. The extradural is intracranial. The subdural is intracranial. Subarachnoid hemorrhage is also intracranial. Intraventricular hemorrhage is also intracranial, but also the intracerebral. But you must differentiate between intracerebral and intracranial. Infections of the brain, seizures, hydrocephalus, vascular changes like cerebral ischemia, cerebral herniations, and lastly, CSF rhinorrhea. Now, we will start with the brain edema, brain swelling. I think I give you good information about this in the second lecture of increased cranial pressure. This can be local around hematoma or diffuse. I mean the brain edema. It is due to intracellular or extracellular, mean either vasogenic extracellular or cytotoxic types of brain edema. due to intracellular or extracellular accumulation of fluid. It leads to raising the cranial pressure, which itself causes problems like herniation, for example. It is more common and more dangerous in children than in other adults. You can see this is the brain edema localized to one side. You can see disappearance of sulci and gyri in this area while they are still present, and this resulted in for localized edema in this side of the brain to cause compression of the ventricle and shifting of midline compression to the other side of the brain. This is scan showing to you clearly the brain edema, edematous brain. You can see that the ventricles are compressed and the sulci and gyri are disappeared. So these are clearly effacement of sulci and gyri, indicating a brain edema, generalized brain edema to the whole brain. Before I leave this slide, I want to tell you that there's other pathology at here, which is extracranial hemorrhage. This is the scalp hematoma we mentioned in the last lecture. Now, the other type of secondary brain injuries are intracranial hemorrhages. And these include the following types: either extradural hematoma, subdural hematoma, which are either acute or chronic, intracerebral hematoma, and last one, subacute hemorrhage. Now, these are quite important subjects, and they are important for you to know as a doctor. They are important for a doctor to know the details of these subjects. They are important for the medical doctor, surgical doctor. They are important in the exam as well. Any time you can suspect the question of extradural hematoma or subdural hematoma to be a recurrent question in the exam. So these are quite important subjects. Different types of hematoma. You can see this is the extradural hematoma outside the dura. It's intracerebral because it's inside the dura. And this is intracerebral hematoma as well. To start with, this is the very most important subject in head injury, which is extradural hematoma. Extradural hematoma, in fact, it is the only top emergency in neurosurgery. And once you will do surgery for the patient as rapid as can, as early as possible, he will be returned back as normal person. Delay in dealing with this patient will result in harmful effect to the patient. You would see just a few minutes. Now, remind the following points that extradural hematoma is a hematoma located between the bone, I mean the skull from inside, and the dura. So it's an extradural, sometimes called an epidural hematoma, the same term. Usually due to trivial trauma, and put this in your mind, trivial trauma, not strong trauma. This is number one. Now, this trauma applied to the head. This will result in bleeding. How or from where this blood will come? The source of bleeding or hematoma will be from either linear squamous temporal skull fracture with laceration of a branch of the underlying middle meningeal artery, so that the middle meningeal artery is the first source of bleeding. Fracture bone edge, because the bone, when it's fractured, also get bleeding from the bone, or laceration of the dural venous sinus, like the supraesophageal sinus. Now, this is quite difficult and dangerous to the patient, and we must be able to treat the patient as early as possible because it is dangerous. Now, I'll ask you, the collection of blood, will it be rapid or sometimes slower or maybe slow? Which one of them, of these three, will result in the severe hematoma or rapidly collecting hematoma? Most of you will think of the artery. In fact, the rapidest one is the section of dural sinuses, then the middle meningeal artery, and the least one or the slowest one is the fracture bone edges. What about the clinical picture of extradural hematoma? In fact, the extradural hematoma will pass into three stages, and these are quite important. حقيقة هاي عندما نسأل الطلاب نعرف الطالب القارئ محضر من الطالب ما قارئ ما محضر. عندما نسأله مثلا يجي ممكن يقول extradural hematoma. He may tell me headache, nausea, vomiting, focus deficit. All yes are true, but this is not the regular question or the regular answer or typical answer for this question. So that you must mention the following things. Number one, stage of concussion. This stage of concussion, as we mentioned to you, that concussion will result in a trivial loss of consciousness, so that there will be a brief period of loss of consciousness. Then, stage of lucid interval. تسمى lucid means البيضاء. In this stage, patient will recover from concussion blood now is started to accumulate gradually in the extradural space. Third stage is stage of compression. Why? Compression because now the blood is collected a big amount, and there's gradual progression of enlargement of the hematoma and compress on the brain tissue. Now, what will happen? There will be gradual progressive deterioration of consciousness, contralateral hemiparesis uh, due to cortical compression, tentorial herniation with compression of the oculomotor nerve and dilatation of the ipsilateral pupil. As the coma deepens, the blood pressure rises and the pulse and respiration slow down. Physio often gives the kind of pressure called uh, the trite, which I mentioned to you in the second lecture, Cushing trite. Okay, of these three things, hypertension, bradycardia, and respiratory low down. So that these are harmful to the patient, and he may die as well. So that put in your mind that any patient present to you having just loss of consciousness, put in your mind that he may have extradural hematoma, um, but put in your mind that this classical picture is found only in minority of patients, less than one-third of cases, because some of them represent with other different presentation. For example, the patient may have no concussion because the trauma is so trivial, but injured the vessel. For example, injured a bone, but the patient got no loss of consciousness, so that he is fully conscious, but he is getting gradual loss of disturbance, loss of consciousness. Other patients present with no lucid interval. Why? The bleeder is so strong, for example, urovenous sinus, and accumulation of blood will not let the patient go to the lucid interval. But put in your mind that any patient having loss of consciousness, you must draw attention to him that he may got this hematoma later on. CT scan will show show the biconvex or lens configuration of the lesion. They are more likely to occur in the younger age group. Now, one of them will ask me, what do you mean by this biconvex or lens shape configuration, and why it happens like this? Okay. Uh, this is a case of exohematoma diagram. You can see the clot at here. And this exohematoma as opened. It's opened after surgery. And this is also exohematoma. Now this is a CT scan of the brain showing the lens shape. Why it is lens shape? You can see this is biconvex or lens shape of the brain of the hematoma. Why it appear just like this? In fact, we have an important thing to mention to you. Let me to try. If I say this is the whiteboard, for example, now I'll draw this one. Imagine that this is the skull, for example. Okay. We have what is called here the coronal suture, and this is the lumbar suture backward. The relationship between the dura and the bone is intimate. I mean, the dura will go just with this one, so that I draw the dura just like this. This is the dura. Then it will be attached to the site of suture. Also attach the site of the suture at here. The same, this one, also the dura, just with it, we have also at here the superior sagittal suture. Okay, this is wrong. This is in fact just like this. Okay, also this one, extradural space attached to this one. Also, this one is the same. Once it go to the suture line, it will attach to it, then be separated. The last one is just like this. Okay, and this is the last one. Okay, this is just like this. Sorry. Okay, so that we have the dual extradural space divided into 6 chambers. This is number one, right, left frontal. then parietotemporal, then occipital, parietotemporal, and frontal. If the blood is collected at here, for example, let me say this is the blood. This is the blood is being collected at here, it will be reached to the side of the suture. It will stop at here, so that how it will be increasing in size, just like this. Okay, just like this, and just like this. You can see this is the blood is collecting at here, but it will be taking this shape of lens shape, so that may reach up to this area. Okay, here also the collection will be just lens shape. So any external hematoma will having biconvex or lens shape. Now, before I'll go out, I'll proceed with the with also let me leave it at now, so that it will be just like you can see lens shape. For example, this is the side of coronal suture at here. Okay, this is the lambdoid suture. So it is separated between the lambdoid suture and coronal suture in the right side. Lens shape biconvex extradural hematoma located in the right side of the brain. Okay, all these sections. Now you can see this section. Now this is in the frontal. I mean between the coronal suture and the frontal. The suture was not reached till now. This one between in the occipital, between the lambdoid suture and not reaching till now the posterior side of the sagittal suture, so that the shape of it will be just like this shape. Return back. Uh, Extradural hematoma is a neurosurgical emergency, and the treatment of it will be by evacuation of hematoma via emergency craniotomy. So that in two words, you will say the treatment of extradural hematoma is emergency craniotomy. Now, if I leave the patient, not do surgery for him, and postpone the surgery, for example, for hours or days, what will happen? Either the patient will die, or he will get a deficit which will be permanent whole life. So that please put in your mind that take assessing care must be taken assessing patients with linear fracture crossing the midmeningeal territory, so that any patient is having loss of consciousness, draw attention to this patient. Also take care of patients having fractures crossing the middle meningeal territory, because they may cause this injury to middle meningeal vessel, and they must be admitted. In fact, you will see that in the next lecture, inshallah, I'm going to talk about management of head injuries. That any patient having a skull fracture, this is an indication for admission to hospital of the patient for at least 24 to 48 hours for follow-up and observation. Now, I told you about this, and this is at surgery. You can see this is the open bone from inside, and you can see the hematoma. We will evacuate hematoma. And why we are saying that the treatment is by emergency craniotomy, not I make it all in the bolt. Why? Not burr or not because I must not only evacuate hematoma, but I must find the source of a bleeding and arrest hemorrhage. This also a hematoma, also other one, and this how it appear on CT scan of the brain as lens shape. Now, the other type of hematoma, of intracranial hematoma, is a subdural hematoma. Subdural hematoma, from its name, it is under the dura over the brain. They are the most common intracranial mass lesion resulting from head trauma. They are classified depending on how long they take to present clinically following the injury into either acute subdural hematoma, which is time present less than 3 days, subacute subdural hematoma from 4 to 21 days, or chronic subdural hematoma more than 21 days of presentation. Subdural hematoma, as you can see at here, it is just behind the dura. And this is also a case of subdural hematoma. You can see it is just below the dura. And this is how it appears on CT scan. Its shape is different, and I'll mention to you how it will appear. It will appear, in fact, as you can see here, as a crescent shape, يعني مثل الهلال, or biconcave, not biconvex. Okay, why it appears like this? Now we'll go back to our whiteboard to see what will happen. Now, The previous draw, I'll draw it again. This is the skull, and these are the coronal suture. This is the lambdoid suture. This is the sagittal suture. Okay, and these are the relation of the dura, as I told you. They will be attached. Then the other one, other dura at here. Also, the other dura is also at here. Okay, now other dura, the 6 chambers of a dura, which you know very well. يعني إذا رسم طبعا ما مو مشكلة بيحكوا علينا، هذا ما مسيطر علينا بالماوس على الرسم. Okay, now this is the dura, this is the bone, and now I am going to draw the brain. This is the brain. Okay, هذا the brain, right and left top of the brain. وهذا يعني كتمثيل شيء بسيط هو ventricles of the brain. Okay. Now what will happen? Subdural hematoma will collect here between the dura and the brain. You can see that this space is open and patent, and the blood can go from here to there in the whole space, so that it will take the shape of a crescent shape, not like exohematoma, which appeared as just like lens shape. Okay, I think you understand what I mean by crescent shape. Now, this is the side of hematoma. You can see the crescent shape. Next. In fact, I'm going to talk in some details about acute subacute hematoma and chronic subacute hematoma. The transition area of subacute subacute hematoma, usually we are facing either acute or the chronic. Rarely to be faced with subacute subacute hematoma, although sometimes happen. Acute subacute hematoma usually due to more severe high velocity trauma and thus associated with poorer outcome. To compare it with extradural hematoma with stop emergency, we said that trauma was severity of it is trivial trauma. Please don't forget that point. Trivial trauma and here more severe high velocity trauma. So that the prognosis of this case of acute hematoma is poor prognosis. The source of bleeding of hematoma include most result from torn bridging veins or focal tears of cortical arteries. This is number one. Cortical lacerations or contusions. And lastly, bleeding from tears in the durovenous sinus from inside. From inside the dural sinus injury from outside, it will result in extradural hematoma. But if it bleeds inside, this result in subdural hematoma. So this is the source of a bleeding in case of acute subdural hematoma. Now, clinical picture, patient will present with a picture similar to that of extradural hematoma, but there is persistent loss of consciousness. There is no lucid interval. CT scan will show a concave, hyperdense crescent-shaped collection because blood follow the subdural space over the convexity of the brain, freely moving up and down, anterior posterior. Hematoma are rapidly evolving lesions, and early evacuation via also craniotomy is mandatory. Also, we said emergency craniotomy and not barhole. Emergency craniotomy. Why? Here the difference in the case of extradural, I return back slightly. Look, you can see, for example, this one. We open? We open the skin, we open the bone, and then we found the hematoma and remove it. The dura, we do not touch the dura at all. While in this case of subdural hematoma, in fact, we are in need to open the skin, number one, to open the bone, number two, and then we will find nothing because the bleeding is below the dura, so that we'll open also the dura and we'll find the hematoma. We evacuate the hematoma and search for the source of bleeding and arrest hemorrhage, and then close the dura, close the bone, and go out. Okay. Now, important question to be asked about prognosis. I mentioned it, but I repeat again that as far as the trauma is more severe, the primary injury will be more severe to the brain, and this carry bad prognosis to the patient. Okay. A case of acute subdural hematoma, you can see the blood is hyperdense with regard to the brain, okay, and taking the crescent shape of a CT scan. Then, which I will not mention it about the subacute hematoma, you can see it is just like the brain tissue isodense, and this is from 4 to 21 days of hematoma. Now, chronic subdural hematoma is quite important. Acquired chronic subdural hematoma, in fact, it is most common in infants and adults over the age of 60 years of age, secondary to slight blow to the head, which may pass unnoticed. And now, draw your attention. This is a slight blow, slight, even less than that trivial of extradural. So that in grading, the most severe is acute subdural hematoma, and then trivial for extradural hematoma, and slight hematoma, a slight trauma, which may pass unnoticed by the patient, happened in case of chronic subdural hematoma. And why? Why is this happen? Why the delay in the presentation more than 21 days? Because you know the following important points. Number one, the patient, for example, over 60, what he is having? He is having brain atrophy, so that the subdural space will be bigger than normal. This is, I mean, capacious. Number two, the blood vessels of this old age will be atherosclerotic. What does this mean? When they are atherosclerotic, they mean when they are injured, they will bleed not so much. They will be slow. There will be slow collection of blood, and it take long time, and slow bleeding and capacious space will result in delay presentation of these patients. The source of bleeding will be of hematoma usually from bridging veins as they pass to the venous sinuses only. The cortex are not injured. The patient present with a progressive neurological deficit more than 3 weeks after the trauma. More than 3 weeks after the trauma, more than 21 days. The initial head injury is often completely forgotten. يعني المريض تسأله ما عندي ما مضروب على راسي نهائيا إلا بعدين ما يكون يتذكر عنده الحالة ماتوا. In CT scan, the acute clotted blood is initially appears white, hyperdense, which you just saw before a while. This one, okay? Then it liquefies, slowly becomes black or hypodense. Hypodense, as you can see, this is hypodense crescent shape. This is a case of chronic subdural hematoma. Now, they should be drained if they continue to enlarge, mainly if they present with features like hemoparesis. They are evacuated by drilling boreholes over the collection and washing it out with the warm saline. Now, treatment differ. Treatment at here is by boreholes. There's no need for doing craniotomy, because they will stop by just this washing with warm saline. They will stop by themselves. Okay. This is a case of chronic subdural hematoma. In the left side, crescent shape along the whole side of the brain. Before I am going to speak about intracerebral hematoma, which is last type of intracranial hematoma, I just want you to put in your mind that these three lesions, extracerebral hematoma, acute hematoma, and cross-subdural hematoma, are very important for you to know their details as a doctor. Number one, for your daily life as doctor, inshallah, in the future, and for your exam. Any exam, you will be asked, for example, essay question, MCQ, or even oral questions, clinical slides, all of them we will ask you. And for example, a good question to be asked, for example, as a say question, I may ask you compare between extradural hematoma, acute subdural hematoma, chronic subdural hematoma with regard to the following points. For example, age of a presentation, number one, the severity of a trauma, number two, the source of bleeding, number three, the clinical presentation, number four, the CT finding, number five, the treatment of the patient, number six, and even I ask you about prognosis of the patient after getting this type of hematoma. So put in your mind these questions are important for you. Now, intracerebral hematoma is the other type of hematoma. After we talk about extradural, subdural, and now we have to speak about intracerebral hematoma. This is the least common of a traumatic hematoma. They are due to areas of traumatic contusions coalescing into a contusional hematoma, which means that to start with they were just contusions, as you saw in the previous CT scan. Not the old CT scans in the back. If I turn back to show you the contusions, you can see this very clear. For example, this one. These are contusions. Okay, these contusions may coalesce together and to be changed to intracerebral hematoma. Okay, this is to put in your mind. Disrupted cerebral tissue release thromboplastin that potentiate hemorrhage and increase the amount of hemorrhage. How you suspect the clinical representation of these patients? In fact, their representation will be just like they have the history of trauma, and they will give you progressive deterioration of features of injury, like consciousness and other things, and there will be focus deficit according to a site of collection of hematoma. CT scan will appear as CT scan hematoma will appear as hyperdense lesion with associated mass effect and midline shift. Large intracerebral hematoma should be evacuated unless the patient's neurological status is improving. So that to start with, we are going to treat this patient conservatively by just waiting for resorption of this hematoma. But if they present with features, for example, focus deficit like hemiplegia, no, please go and treat them by surgery. Small intracerebral hematoma may not require removal, but be aware that they can expand, so that put the patient under observation for any deterioration of consciousness or any for appearance of focus deficits, so that we will interfere. And surgery here, put in your mind how we do surgery for intracerebral hematoma. Here we open the skin, we open the bone, we open the dura, and we see nothing because the hematoma is inside the brain. So that we will open the brain by gyrotomy, and then we find hematoma, and evacuate hematoma, find the source of bleeding, arrest hemorrhage, and then close. I not say close the brain, no, close the dura, close the bone, and close the skin, and go out. In fact, regarding prognosis of this patient, according to their severity of trauma, number one, according to the amount of hematoma, number two, and according to mainly to their clinical presentation. If they present early and they present with no focus deficit, for example, they will return to normal. For example, this is a case of intracerebral hematoma, area of intracerebral hematoma after death of the patient. This is the postmortem specimen, and this is quite clear collected very big hematoma in this slide, in the right parietemporal area, as well as here. This is left parietemporal area, big hematoma for two patients, with one in the right, other in the left side of the brain. For example, this one, you can see that the midline, there is no midline. So midline is still in its place, can be treated conservatively. While this one, the shifting of the midline, compression of the ventricles, I think that this one is in need for surgery rather than this one. Subarachnoid hemorrhage. Trauma is the commonest cause of subarachnoid hemorrhage, although aneurysms are the most common cause of spontaneous hemorrhage. Subarachnoid hemorrhage. Trauma subarachnoid hemorrhage is managed conservatively because they resolve by themselves. There is no need for surgery unless this subarachnoid hemorrhage result in one of the complications which I mentioned to you in the third lecture of hydrocephalus. If the patient got hydrocephalus, in that case, there will be a need for surgical intervention. I mean by shunting of the ventricles. Now we finished the second type of secondary brain injuries after brain edema and intracranial hemorrhage. Now the other, I give a few notes about the other secondary brain injuries. I mean, including the serious infection, seizure, hydrocephalus, vascular changes, cerebral herniations, or CSF rhinorrhea. Regarding serious infection, the cause of serious infection include penetrating cell trauma, even if by sharp injuries, like sharp injuries or bullet injuries, and even if it is compound depressed skull fracture, may result in infection. Depressed skull fractures, if mainly the opened one, or sometimes the closed depressed skull fractures, if they were near area of air sinuses, nasal air sinuses. Basal skull fractures also, because mainly in the frontal and in the temporal, sigmoid temporal, in the frontal, because they will be connected to the nose and result in CSF rhinorrhea and may got infection, or to the near the ear and result in CSF photoria or tourniquet infection. All these will provide border for CNS infections, and we will treat infections uh, accordingly. How they present? They are present to me either as meningitis or as a brain abscess or subdural empyema. These can all exacerbate situation of the intraventricular pressure and need urgent interventions. Other secondary brain injuries are seizures. They can increase both brain metabolism and blood flow, therefore increasing intracranial pressure. And seizures may be, in fact, I don't want you to go into the details of seizures after post-traumatic seizure. They are a huge and very big subject because maybe early and maybe late presentation of the patient. So that if you suspect seizure or have seizure in the patient, then start anticonvulsant therapy. Hydrocephalus, as we mentioned in the third lecture, that acutely due to obstruction of CSF outflow due to intraventricular blood, like for example, fourth ventricular bleeding or third ventricular bleeding, they result in obstructive hydrocephalus, or delayed post-traumatic communicating hydrocephalus due to impaired CSF reabsorption following traumatic subarachnoid hemorrhage. And both of them will be in need either for if the bleeding is suspected to be temporary, then I will not do shunting. I might do just external drain. I'll drain the CSF to the outside and wait until it be crystal clear, complete absorption of blood. Then I can remove it. Also, if the CSF is not clear, for example, containing blood, at that time also I will do external drain, because if I do shunting, the patient may not need shunt, number one, as whole life, and number two, that the blood clot will close the upper end of the shunt and failure of the shunt will happen. This is a case, for example, intraventricular blood, which can lead to hydrocephalus if the blood clot go to obstruct, for example, foramen of Monro. So this is a case of intraventricular hemorrhage. Also, you can see spots of blood at here, and also there is subgynea hematoma in this side. Now, other secondary brain injuries, vascular changes, like cerebral ischemia, just like CVI, just like CVI. This occurs after severe head trauma and is caused by hypoxia, impaired cerebral perfusion, or both of them. The injured brain loses its ability to auto-regulate and so be unable to maintain cerebral blood flow with a decreased blood pressure. Toxic chemicals accumulates like glutamate and free radicals will lead to neuronal damage, more and more neuronal damage to the brain. In fact, they present just like a case of CVA. I mean, for example, hemiplegia, hemiplegia, etc. Cerebral herniations, I mentioned the details of this to you in the second lecture of against the blood pressure, and what each one of them which will lead. What will lead? The subfascial herniation, ankle herniation, tentorial herniation, and dorsal herniation. I mentioned all of them, and the rapid review of this image. This is a subfascial herniation. This is the ankle herniation, tentorial herniation of the midbrain structures, and last the tensile herniation through the foramen magnum. The same presentation as well, and there's the subfascial herniation to the other side, and shown also by this MRI subfascial herniation. Also, this is the ankle herniation, and this is ankle herniation. This is the cerebellar tonsil herniation. As I told you, that this is the limit of the normal cerebellum. This is protruding or herniating through the foramen magnum. This is post-mortem specimen. Foramen magnum also herniation. You can see it just like this, because normally will be this is this limit, and this is considered herniation. The last type of secondary brain injuries is CSF rhinorrhea. I told you about this in the last lecture when we spoke about skull-base fractures. So CSF rhinorrhea from there occurs secondary to fracture involving the paranasal sinuses, frontal, ethmoidal, or sphenoidal, associated with the dural tear. A piece of brain tissue is forced into the dural tear and prevent its healing. I mean, this brain tissue will enter between two edges of the dura, and there will be no healing of the dura, so the CSF will still coming out and through the cribriform plate go to the nose. This complication is able to be followed by meningitis, so that the patient is treated early with antibiotics in the hope that this CSF rhinorrhea may stop. In fact, the patient may go CSF rhinorrhea or otorrhea, but we know that most patients with otorrhea will stop rapidly than those with rhinorrhea. And rhinorrhea, they will stop, but if they will stop, it will not stop. In that case, we will proceed with surgery. In the case for surgery, I mean repair of tear, and this surgery, in fact, quite important. When I asked most students what are the indications for surgeries in case of skull base fractures, one of them told me loss of consciousness. I said, why loss of consciousness? What's the relationship between loss of consciousness and the surgery? No, the indications for surgery in the case of rhinorrhea, persistence of rhinorrhea more than 10 days, the presence of a fracture involving the frontal or ethmoidal sinuses, I mean frontal ethmoidal air sinuses, and because they are able to get more infection, rapid infection than other areas. And lastly, occurrence of meningitis. Once occurrence of meningitis, we must deal with this patient by craniotomy and repair of the defect, sometimes endoscopic repair of the dual defect at the base of the skull to stop this rhinorrhea. يعني من الاشياء نعاني منها مع المرضى ومعاليهم مثلا عندما يجي عنده يظل عنده rhinorrhea more than 10 days, we ask them for surgery. What surgery do you do for my patient? I tell them I will do craniotomy. Oh, this is major surgery, dangerous surgery. Please give me a chance. No, your patient got meningitis. He may die from this. Postpone it later on. Then the patient will present to us with frank meningitis. They said we were wrongly behaving because we refused surgery. Now, once he will get resolved meningitis, please do surgery for him. Once he resolved from meningitis and return back normal, they will take the patient outside to their home and do no surgery until 3 or 4 times of meningitis. Then they will agree about surgery. Okay. So that is in the case for surgery in the case of rhinorrhea are quite important for you to know. And by this, we are finishing our second lecture of head injuries. And inshallah, in the next lecture, inshallah, I am going to talk to you about management of head injuries, which will be containing very important information to you. إن شاء الله ما كنت مزعج بالنسبة لكم المحاضرة. I think I want it to be very beneficial to you. Also, as I told you always, if you have any question, don't hesitate to contact me to answer these questions. Thank you very much for all of you. Wassalamu alaikum wa rahmatullahi wa barakatuh.